afternoon, everybody. Welcome to the Teleon lunch tea time symposium. So the title of the satellite symposium is Celebrity Surgeons Meet Celebrity IOLs, and just like celebrities in Hollywood, sometimes the celebrities are very busy to be able to come. So we've got all the talks basically developed over here. We have a slight difference in the change of the speakers, but you'll hear all the presentations that they were going to deliver. So we're going to start with basically Noël, who's going to basically give the first talk that Rudy was going to give on a randomized controlled trial on the visual function after bilateral implantation of 2 novel extended depth of focus lenses. Thanks, Noël.
Thanks very much for the introduction. I start the presentation myself. As you said, on behalf of Rudy Nuijts and also my colleagues Berend Schot and Van der Biggelaar, I want to give this presentation where we did a randomized controlled trial on the visual function comparing 2 EDOF lenses, and that's ACUNEX Vario and the Vivity lens. When we look, this is a clinical survey that has been done by the ESCRS asking what type of presbyopia correcting IOL technology do you use most of the time in your patients. And you see that this more or less over the last 6 years rather stable, and with the use of trifocals remaining about 50%, but EDOF lenses doubled since 2016. The ACUNEX Vario IOL is a single-piece IOL, as you might know. It's a biconvex optical design. It has, you see here a picture, of course, a sector shape near the vision segment with 1.5 diopters and 3 diopters max add. An aspherical posterior surface, and it's spherical aberration neutral. It's made of hydrophobic acrylate with a C-loop design, and the A constant is also written there. The Vivity IOL is also a single-piece IOL with a biconvex optic design. You see a picture of it here, with in the middle a small achelet, which Alcon calls the X-wave technology, with an aspherical anterior optical design and a posterior surface, and modified L haptics and the A consent as said before. Here you see the differences between the 2 lenses. Both of them are hydrophobic, and they are 6 mm. The ACUNEX Vario is 12.5 mm, while the Vivity is slightly bigger. And the dioptric range is the same from 10 to 30. We set about to compare these lenses in a randomized controlled trial. With that, we did this in 32 patients. We divided that in 2 groups. Obviously, 16 patients in one group. 1 patient dropped out at the last minute, and so we had 15 patients in the other group. We did follow-up of 1 week, 1 month, and 3 months. And I will show the results of the 3 months checkups. Patient inclusion criteria: bilateral cataract and postoperative astigmatism to be expected lower than 1 diopter, and of course expected visual acuity of 0.3 logmar or better. No ocular comorbidity or surgery in the past. So the purpose of the study was to a randomized controlled trial to show non-inferiority between these 2 lenses at 3 months postoperatively, that in patients that underwent bilateral cataract surgery. We did a mini monovision approach, which is usually done with these kinds of lenses, where you implant the dominant eye for ametropia and the non-dominant eye slightly myopic, anywhere between -1/4 or -3/4 of a diopter. As said, we had 32 participants. The primary outcome measure of the study was the binocular uncorrected intermediate visual acuity at the intermediate distance of 66 centimeters. And the secondary outcome measures were all the other visual acuities at distance and near, uncorrected and corrected, monocular and binocular. We made the focus curves, I'll show you later. We measured the contrast sensitivity, and also at 3 months we did patient satisfaction, and we looked for spectacle independence. We asked the patient, and visual disturbances. So here are actually the preoperative data. It's quite a lot of numbers. but as you can see that patients in the Vivity group were slightly older, and it was also statistically significantly different. And the actual length in the Vivity group was actually larger, and we had more myopic patients in that group. These confounders, they were thought to be confounders, so the data was correctly corrected for these confounders for the statistical analysis of the results. So here are the monocular visual and refractive outcomes. We have divided it in dominant eyes and non-dominant eyes. We see that the sphere and the cylinder are significantly different between the groups, with postoperative cylinder in the Vivity group of more than half a diopter, and resulting in an uncorrected distant visual acuity that is slightly worse in the Vivity group and better in the ACUNEX group for the dominant eyes. In the non-dominant eyes, there were no statistically significant differences. So the refractive outcomes again, for the dominant eyes and the non-dominant eyes, and we see in the light blue the ACUNEX Vario IOL. Most of the patients were between -1 and +1 diopter, with only a few that were outside of these spherical equivalent diopters. And as far as the mean refractive prediction error, so that's the difference between what you're intended to do and what the actual outcome, we see that the prediction error was rather small, with although it was significantly different between the two groups. The uncorrected visual acuity binocularly, and this was our primary endpoint. That's where the red square is. So the uncorrected intermediate visual acuity, and it's in logMAR. So the ACUNEX Vario did better, almost a line better than the Vivity IOL. And here you see it for the other distances as well. So for distance visual acuity, the mean uncorrected visual acuity was 0 in the ACUNEX group and 0.08 in the Vivity group. And also at near, the ACUNEX Vario performed a little better than the Vivity IOL. So corrected visual acuity, there were also some slight differences, with the ACUNEX Vario being slightly better overall. As promised, the defocus curve, the ACUNEX Vario is in light blue and the Vivity IOL is in dark blue, and it's comparable over the range of +2 to -4, with 3 points where the ACUNEX Vario is slightly performing better than the Vivity IOL. And the ACUNEX has a continuous range of vision from +1 to -2.5. So that's here. Contrast sensitivity binocularly, we see here in photopic conditions without glare and with glare. It's comparable between the two groups. And spectacle independence, here you see the results for the distance vision, intermediate vision, and near vision. And for distance vision, most of the patients never or rarely use spectacles in the ACUNEX Vario group. And for example, for near vision, this was like 38% in the ACUNEX group and 27% in the Vivity group. Overall satisfaction rate was very high. In the ACUNEX Vario group, 96% of the patients were happy. And in the Vivity group, almost 90% were happy. So we asked the patients, how often do you experience photic phenomena, like halos and glare and starbursts? Here you see the results of that, which are also comparable, and actually very small amount of people that experience these problems. It must be said that we had only 2 patients that had bothersome halos and glare. So although they were there, only in 2 patients they were bothersome. The reading speed is depicted here, which is similar between the 2 groups. No statistically significant differences found. So in conclusion, bilateral implantation of the ACUNEX Vario and the Vivity IOL, when targeted for minimonovision, showed in our groups better binocular uncorrected intermediate vision for the ACUNEX Vario IOL and a larger range of continuous, a larger continuous range of vision and comparable contrast sensitivity and reading speed, higher spectacle independency, and fewer visual disturbances for the Vivity IOL. And the overall conclusion is that the visual performance of the ACUNEX Vario is non-inferior to the Vivity IOL. And with that, I want to thank you for your attention.
Stefan's going to present now on top part of Oliver Findl's talk on binatural extended depth of focus EDOF lenses. Thanks, Stefan.
Okay, thank you very much. I work together with Oliver Findl here in Vienna, and I would like to share our findings of this study where we used the EDOF version, so the ACUNEX Vario, and we compared it to the monofocal platform. So as we heard also in the first talk, spectacle independence becomes more and more important as cataract surgery becomes more and more successful. So we have more patients for the wish of being spectacle independent. So, and as we all know, there are different ways for achieving that. So let's say the low-tech version would be to use a so-called monovision, where you use 2 monofocal IOLs, set one for the distance, the other one for intermediate range to increase spectacle independence. But of course, in these patients, what you have is that they still need to wear glasses for the reading distance, especially when you have very small print. And the second thing is, as you put the focal points apart on both eyes, we see that, or there could be an impaired stereo vision. And we will talk about that in a few moments. The second thing you can offer your patient is the multifocal IOLs, and there are quite modern lenses now available, achieving good results in terms of spectacle independence. But what we see in our clinics is, or what we're concerned about is, these dysphotopsia, which occur by definition in every patient, and we need to talk to the patient and to explain it to them. And then the third version, or the third possibility, would be the EDOF form, extended depth of focus. These lenses enhance the intermediate vision. They show to have a good contrast sensitivity and probably less dysphotopsia. So in our study, we used the same IOL as in the previous presentation with the ACUNEX Vario. This is again a hydrophobic IOL. You can see the dimensions of the lenses here. This lens has no angulation, and what it makes different from the monofocal lens is this segment here on the image in the inferior part. This is a so-called planted transition zone. We use the lens, this lens has an addition of 1.5 diopters, so it should increase the intermediate vision at about 66 centimeters. And due to the fact that this superior part here on the IOL is free of any rings or any other design features, it should have good distance vision as well. Okay, in our study, we compared this lens I mentioned now with the same platform, the ACUNEX AN6, without this blended transition zone. And our main outcome parameter was the spectacle independence. And the secondary outcome, we looked into the stereo vision in this patient. So how good both eyes can work together. And then, of course, we looked into the different visual acuity parameters, especially uncorrected and distance corrected, distance, intermediate, and as well as near visual acuity. So we designed the study, which was a prospective randomized monocenter trial. We included 50 patients, and these were randomized in 2 groups, so 25 in each group. 25 received ACUNEX Vario and so the EDOF lens, and the other 25 patients received the monofocal version. And this is important that all eyes we included, or all eyes in our study, was set for emmetropia, and we aimed for about -1/4 diopter. Our inclusion criteria were basically, of course, this was a cataract population, so all patients were routinely scheduled for cataract surgery, and they need to have the wish for spectacle independence. Of course, we included patients who have a good or have a very good predicted outcome, so they must have a good postoperative vision, at least a predicted good postoperative vision, and also a low astigmatism. For exclusion, we excluded basically all other eye diseases in specific amblyopia, any pupil issues, previous surgery, so anything which could lead to altered vision or a reduced and altered outcome. So the study visit schedule you can see here, we had 4 visits, 1 week, 2 months and 6 months after the procedure, and these were the measurements we performed. And so we started with the questionnaire, so the subjective impression of the patients, and we assessed the quality of vision and also the spectacle independence. We used a routine, we did a routine ophthalmic examination, of course, and then, as mentioned, we assessed visual acuity, best corrected, the uncorrected, and the distance corrected visual acuity, distance, intermediate, and near, and then the stereo vision I will show you in a minute. The questionnaire, quality of vision, investigates 10 items. A few of them you can see here. So all kind of photopic phenomena which can occur. And each patient was asked to score each item in 3 categories. So first is the frequency. So how often do you have the symptom? How severe is the symptom is the second category, and how bothersome is in a total for you. So they graded it on a score, or gave it a score from 0 to 3. So for instance, the glare doesn't occur at all or occurs every time. The patient can adjust on this scale. With the questionnaire of spectacle independence, we handed them to the patients, and we basically asked, do you wear glasses? How often do you wear glasses? Which kind of glasses do you wear? And what about your daily activities without your glasses? So how well can you go through the day? How well can you do what you want to do without wearing the glasses? For the stereo vision test, we use the so-called HAS application, which is a software-based tool to measure stereo vision. The patient were asked to wear these 3D shutter glasses, and they looked at the screen with a program or with the software looking something like this. And the patient needed to judge where he can see a 3D object. So a 3D object is presented to the patients, which tend to have a different disparity, so a different resolution, so to say, and the patient needs a response in which quadrant this 3D object appears. And it's similar to visual field examination, where disparity goes up and down, and the final finding was the threshold where the patient sees about where 55% of the responses are correct, quite similar to how we test the visual field. So in that case, the printout suggests or gives us this line, and in that case, when we look about 55% correct, we come about to our log2 threshold of 6.25, and this we used for further analyses. So when we come to the results, I would like to share the results for 2 months, as the study is still ongoing for the 6 months visit. Recruitment is finished, so we included all 25 patients in both groups. Unfortunately, we have to exclude 5 patients from the EDOF group and 3 from the monofocal group, and 2 is still ongoing, leaving us with 20 patients for today's results. With regard to the baseline characteristic, age, and the sex distribution, we found no difference between the groups. So first, outcome, and simultaneously our main outcome is the spectacle independence. And when we compare on the left side, when we ask them the question, how often do you have to wear your glasses? The responses for always were lower in the EDOF group as compared to the monofocal group, and for never was also larger in the EDOF group as compared to the monofocal group. So the EDOF group seems to wear glasses less often. So when we ask the patient, what is about the vision when you don't wear your glasses? And again, for distance, it was comparable. So the question was, do you have a good vision without glasses? Basically, yes or no. And the responses were similar for distance for both groups, but when we look at the near vision, more patients responded to this question with yes in the EDOF group. With regard to the daily tasks, they performed without glasses. What we see again for distance, this is the third column here, it was similar in both groups when it comes to tasks which are related to near distance or for the intermediate range. We found slightly better values for, or the response from the patient were better for the EDOF group in that case. When we look at driving at night, that's interestingly here, the responses were slightly better, but not much difference at all for the monofocal group. With the refraction, or the aimed refraction and the target refraction was good and comparable between both groups. It means that with both lenses, we achieved our target refraction quite well, and we had up to 80 or 90% within half a diopter. I'm sorry, for both groups. And now the visual acuity, and this is the other very important outcome parameters in our study. For distance vision, all patients achieved very good results. Almost 100% had uncorrected distance vision acuity of 0 logMAR, so very good results for distance vision. I would like to draw your attention on the top right corner now. This is the intermediate visual acuity, where I present you the uncorrected intermediate vision and the distance corrected intermediate visual acuity. And we see when we compare the EDOF group with the monofocal group that these values for both were higher in the EDOF group. Lower as compared to distance, of course, but again, in the EDOF group, these proportions were much higher as compared to the monofocal group. And a similar thing I can show you for the near vision, the same thing. We have the uncorrected near visual acuity and the distance corrected near visual acuity, and we see these values were again higher in the EDOF group as compared to the monofocal group. The stereopsis, this was also very interesting. Again, the value which I showed you here is the threshold where 50% of the 3D objects were seen. Interestingly, we found a difference prior to the study. So the difference in the stereopsis was there at baseline with worse values for stereo vision for our EDOF group. But nevertheless, after the procedure, both groups achieved very good stereo vision, and there was no difference at all. Similar results were found for the other tests, so the Titmus fly stereo test. We used these small circles to determine the disparity, so the angle of stereopsis, and again was a significant reduction. This is most likely due to the fact that they were cataract prior to the surgery, of course. And with regard to the questionnaire, the quality of vision, what we found is, I would like to show you all three categories here we asked our patients. So the first is the frequency, and I ordered it with the most frequent on the right one. What we see is that in both groups, glare seems to be the most prevalent after 2 months, and it seems that halos are slightly or are more frequent in the EDOF group as compared to the monofocal group. But when we look at when we ask the patient how bothersome or how severe were the symptoms, what we see again, glare was the most bothersomness, and also halo the second one for the EDOF group. But what we see is, when we look at the severe group, is that the most patients, so had never, this is the light blue, not at all, this is the light blue, and the darker blue is mild, so around 80 to 85% only have none or even mild symptoms or a mild severity. And none of them said that the symptoms were severe. Okay, so in summary, the spectacle independence is increased when you use the ACUNEX Vario. Again, I would like to remind you that we set emmetropia for both eyes. But even in that case, the intermediate and near vision is improved as compared to the monofocal platform. Stereo vision is good, though we found a difference at baseline, so prior to the surgery. After the procedure, stereopsis improved and was comparable to the monofocal group. Visual acuity, intermediate and near visual acuity, so uncorrected as well as distance corrected, was better when you used the ACUNEX Vario lens. And the quality of vision symptoms, would I say at the moment, is comparable between both groups. The glare symptoms is comparable to the monofocal group, and the halo, which are seem to be more frequent in the EDOF group, are only mild or moderate when it comes to terms of severity. So to conclude, the ACUNEX Vario is a safe option to increase the spectacle independence, and improved intermediate and near vision, as well as good stereopsis is achieved when you use the ACUNEX Vario. And with that, I would like to thank you, and I wish you a good Congress, and I hope you have some time also to enjoy our beautiful city of Vienna. We have very nice weather, and so thank you again. Thank you.
That's very interesting. So I'm just going to ask you just a couple of questions from the talk. So again, one of the things I was going to ask you, I know the study was going out to basically 2 months, and you showed the lens picture with the segmental focus there. So one of the things I was going to ask you is stability. Okay, of that lens. Rudy mentioned about the positioning of the lens when you implant it inside the eye, so basically superior inferior with a segment on the inferior side. Do you think that's potentially an issue? Because of course that's where basically they're focusing for the intermediate and near. And if so, is there anything that you do to mitigate, or is that something you're going to look at in the long term, especially if you get capsular fibrosis basically occurring?
Yeah, thank you. That is a very important point. With these lenses, or with this type of lenses, of course, centration and positioning of the IOL is critical that it works well. So when there is a movement of the IOL and the segmented optic would come closer to the optical center, or to the, then it could, of course, change the results. But in our impression, or in our cases, we haven't seen any shift or any movement. But we're also only 2 months now.
Okay. And is there any sort of level of maybe angle alpha that you'd think, okay, maybe it's like too much with where the lens will then center, that you may want to think about maybe not using this kind of lens, or have you started looking at that data, or?
You mean with kind of amount of decentration?
Yeah.
Oh, I can't tell you now if there's any when at which this decenter level, so to say, vision gets worse. In my impression, in a patient I have seen in this study,
yeah,
we haven't observed any decentration at all. So maybe.
Okay. No.
Yeah, we measured the decentration. On average, it was less than half a millimeter.
Less than half.
Less than half a millimeter.
Okay.
Yeah.
So it's quite a small amount.
Yeah.
And they still had functional effect.
Sorry?
They still had half millimeters, so not 500 microns. Less than 500 microns.
Yeah, 5 millimeter.
Okay.
Less than half a millimeter.
Yeah, okay. Yeah. But it didn't have an effect on the ones that had some decentration. There was no effect on functional intermediate vision.
No, we didn't measure any effect of the outliers as well.
Yeah.
So, no.
Okay, all right, great. And so if you flip the question then, for people who may be starting to use this technology, I mean, Stefan, you showed a basic comparison to monofocal. Okay, is there any situation where, is there any downside of basically just using this lens? I mean, I know there are slightly more symptoms that you showed in the subjective questionnaire, but like you basically explained, they were quite basically mild symptoms. So is there any downside from using this in replacement of basically a standard, but in a situation with a standard monofocal?
I mean, what we found in our study, there might be a slight chance for having halos as well as compared to other designs. But at least this is my impression from the patients we did in our study, is that they say they are there, but they are not bothered at all. So of course we need to explain it to our patients that this is a possibility. Yeah. I think it's still in these kind of lenses. Decentration we mentioned already. It seems that this type is a little bit less dependent on pupil size, right, due to the design. But I would basically go for the same informed consent or the same descriptions as for other multifocal IOLs.
Yeah. Okay. And so just on that, I know the cases in both your studies were basically normal eyes. So I mean, any thoughts about, say, post-refractive surgery or post-LASIK eyes? What would be your thinking in the situation? Because often in these situations where you can use obviously monofocal or even enhanced monofocal lenses maybe provide a little bit of an attractive option in this situation. Is this something that you'd maybe consider?
Probably this is a refractive lens, so this is a refractive element.
Yeah.
Maybe this is a bit better after refractive surgery, but I haven't any data now for at least for myself.
No, we have not enough data on that to answer that question. No.
Okay. So I think it's something maybe, I mean, obviously there's a slight increase of ectoptic phenomena, but maybe in somebody who's got maybe slow spherical aberration with one of the modern lasers, or more recently, maybe an option basically to give them a little bit more spectacle independence, as opposed to somebody with a high spherical aberration, basically lends itself from there as well. But yeah, okay.
And this is as you mentioned in a clinical study, we always go for perfect healthy eyes. But this is, to be honest, rarely true in the daily clinics.
Yeah.
When we have patients with corneal issues, when we have patients with retinal issues, glaucoma, when we have dry eye.
Yeah.
And probably, I mean, in our patient population, this was a cataract population, so these are older patients, or let's put it out the way, they're not very young patients. So the likelihood that that in this patient group we find other diseases like dry eye, which is important, of course, would probably change the thing.
Okay, so I mean, both of you obviously practiced in Europe, so generally the winter times in Europe are much darker than Singapore, I can tell you. So we have very high levels of illumination even in winter time. But I mean, just on that note though, driving, nighttime driving, I mean, for photooptic phenomena, because obviously an issue where you're driving, I mean, that's something that you guys must both consider when you're basically doing cataract surgery in that population group. Would you feel that this may be a nicer option with respect to that compared to say, a refractive a diffractive trifocal lens?
Yep, probably yes. So as I showed you, the results or the subjective question for nighttime driving was the responses were a bit less in the EDOF group as compared to the monofocal. We will rejudge that when we have the full data set. So maybe we can we need to look deeper into that question. But yes, definitely, especially when you drive at night, and also there are a lot of professional drivers who have to drive at night. In these patients, we need to be cautious, of course.
Okay. Do you have the same experience, Noël, in Netherlands as well with the nighttime driving?
Yes, I think you need to be careful when you counsel your patients. That should be one of your questions as well. If you do a lot of nighttime driving, and then obviously you choose the lens that best fits the daily life of the patient. And we have talked about it in the past. Of course, if you implant certain lenses, then you can have problems with nighttime driving. Yeah, and I think these lenses are less. They're more forgiving.
More forgiving.
Yeah.
Okay. So Thomas is going to talk about verification and evaluation of functional visual results after implantation of multifocal ACUNEX Vario. Thanks, Thomas.
We do this study as a project for the company with our team in Frankfurt, where we actually do most of our studies on presbyopia correcting intraocular lens. If you see the landscape of multifocal lenses, we put this slide together in order to make sure that if you look at premium IOLs, monofocal aspheric lenses is on top of this. We have now the monofocal plus lenses. All these lenses have good distance visual acuity, some intermediate, very slight intermediate from what I have seen so far. The EDOF lenses are much different. They go in the direction that they can correct for distance and intermediate. With a little mini monovision, you can achieve even more. Then you have the multifocal lenses. They achieve usually around everything with some downside. And the question is when accommodative IOLs are coming. I think it's exciting times. We actually in Frankfurt, we start a accommodative IOL trial pretty much soon this year with a new IOL. This is really exciting work. But on the other hand, whatever multifocal lens, or let's say, or whatever accommodative IOL we will have, we always have to ask our question, how permanent will these corrections be? And therefore, it's important to talk like a topic today. Here are the multifocal lenses. I'm investigating lenses for now more than 30 years, actually starting with the diffractive trials with the 3M trial and then rezoom, and you can see a lot of lenses which we put here on the evolution base. We also looked at a diffractive lens from 2000 to 2015, all iterations. It's interesting to see this from one company, that's Alcon, but from one company, what they have done in order to make sure that lenses, although the technology was a diffractive technology, have increased. And of course, we have learned so much. For example, toricity, how to correct toric, is so important in patients who do this. So you have to address astigmatism. And we also knew that the intermediate outcome for patients is so important, because I can remember still when we had the bifocal lenses, very good for distance, good for near, but they had a gap, they couldn't read the computer, and that was addressed. So that's very important. So here are publications along this side with the focus curve and all these things. Now, I'd like to summarize this paper. It's a highly cited paper. We just had the Journal of Cataract and Refractive Surgery yesterday, and we saw in the publisher's report that this was the fourth highest cited article for our impact factor, because it talks about the extended depths of focus IOLs and summarize them. Small aperture, bioanalogical, which we don't use very much, and then the diffractive and the non-diffractive intraocular lenses. The introduction I'm doing today is lots of the multifocal lenses are available on the market, and you, of course, have to choose, because you will run here on this beautiful congress, on this beautiful exhibition area, and you will have seen, or you will see a lot of companies, they have great products, and one day you have to decide for your patient. I think it always helps if you look at data outcome, really data outcome from good studies, and of course then your personal experience and personal experience from peers, which is also important. Multifocal lenses provide good visual acuity in far, intermediate and near, which I already said to you, and the premium IOL have different optical designs. The ACUNEX Vario Max has a refractive design, and you see the lens here on the right side. We will talk about that. Now, the optic design, you can see a diffractive and a refractive design. If you look at the diffractive design, 20% loss of light due to unused energy is in diffractive lenses the norm. Now, light transmission is only 78 to 86%, and you have a little bit more when you look at refractive designs, because you only have these two parts. So that's interesting just to look at this. Now, the purpose of our study was the outcome measurement on visual acuity for different distances, range of vision, patient satisfaction, spectacle independence, visual quality, refractive outcomes in cataract surgery implanted with this, and it was a non-toric version of that Vario Max IOL. Now, already looking at this slide, you understand that this is really some work, because you have to take the patient after surgery, bring them back to your department or to your study facility, and then go to all these measurements. And it becomes more and more difficult to implant, or let's say to include patients, because it's their time. They have to come back to the clinic and they run through this. It's not easy, I can tell you, but university clinics try to do this. And of course, we try to put together these data. Now, the interim analysis, because it's a prospective single-site clinical trial at my department in Frankfurt, including patients after bilateral implantation of that lens. Examination at 3 months follow-up. We looked at binocular uncorrected and corrected visual acuity at distance, intermediate and near. You can see here the abbreviations that help usually, because it's long. When you write up these papers, you always have to use these long words. So the abbreviations help. If you're interested in how to do that, that's published in the Journal of Cataract Refractive Surgery 2010. I put a little table together where these are summarized. In every journal, you find them in the beginning. Spectacle independence, patient satisfaction, and visual disturbances were also evaluated. The focus range from -5 to +2 in half a diopter steps was also done. So in terms of the inclusion-exclusion criteria, bilateral cataract surgery, patients above 30 years, that's not the norm because usually are much older, of course. Post-operative astigmatism should be less than 0.75. When you take that with a pentacam, which takes into account total corneal refractive power, which is sum of the anterior and the posterior part of the cornea. 3 millimeter low mesopic pupil size and not larger than 6 millimeter in the range, because we wanted to have no outliers like 7 millimeter or very small pupils. Center shift less than 1 millimeter in our pentacam AXL measurement, of course, an signed informed consent. This was the inclusion, and the exclusion criteria: amblyopia, strabism, irregular astigmatism, previous ocular surgery, so in other words, post-LASIK, post-PRK, or ocular diseases which causes decrease in visual acuity below 0.3 logMAR or worse, and, as I said, previous corneal refractive surgery. So here we have all the results. Monocular subjective refraction. You see the number of eyes, and you published that 2 of the 10 patients needed spectacles in some visual tests 3 months post-operatively. That's the only thing. So 8 without glasses at that point, and you can see the outcomes pretty much on the 0 line. Remember, in logMAR, that is 20/20 or 1.0 in decimal unit. So, and you look over the range here, this is the results for the refraction, monocular subjective refraction, so pretty close here. In terms of the uncorrected visual acuity, you can see here preoperative and then at the various stages at 1 to 7 days in the second row here, and then 4 to 6 weeks and 3 months. And you can see here we have 34 patients in our eyes included, 24, 22, and 20. So we're not yet 100% right, fulfilled, but you can see that there is an increase in the uncorrected distant visual acuity. There is also an increase in the uncorrected intermediate, and there's an increase in the uncorrected near visual acuity. So that provides some not perfect data on the first week or on the first days, where we see our patients, maybe some corneal edema. That is, of course, normal, but you can see the most important are the long-term data, let's say 4 to 6, 3 months post-operatively. This is monocular distance corrected. Corrected usually is better. Let's go back. You can see always this is uncorrected, this is corrected. So if you correct this residual refractive error, you can see still a little bit better. This is a lower number of patients which we have put here together with the bilateral implantation of the lens. Uncorrected visual acuity here, again, the number of patients at 4 to 6, 3 months, binocular. This was distance corrected, and this was uncorrected visual acuity. So to say, you see these outcomes. And then here we have the binocular distance corrected visual acuity again for the distance. This is an important slide. That is our defocus curve. This usually tells me pretty much our lens works, because if I see the defocus curve, which is a lot of effort, you see here that our team refracts them from +2 down to -4, goes all the line with half a diopter steps, and you can see that basically this curve follows pretty much a pretty good line. You have only this little intermediate dip in the area of -1, but beside this you have pretty good outcome at the 3 months post-operative defocus curve. In terms of contrast sensitivity, at the moment we see pretty good outcome in logMAR. Contrast sensitivity, photopic and mesopic. Mesopic a little bit worse, 1.33, and photopic 1.45. Of course, we have to compare this in our final data to the literature. Optical quality in different light conditions. Optical quality under these light conditions total, bright light, normal light, and low light. You can see here this. And you can see the outcome for double images, blurred vision, starburst, and halos and glare, very low. Because halos is something what I find in diffractive lenses to be pretty high. And this is not the case. So 7.9% is very low number. In comparison, that's at low in the range of I see my non-diffractive EDOF lenses, maybe even a little bit better. If you look here, optical quality, looking at at these images at different diet position. You can see they put this on the slide, and again here you have this at the various time points. They put this together on this slide. So I just have to conclude, because it's an interim study. We're still working on our outcomes. We have almost like 10 patients to follow up. Visual performance of the ACUNEX Vario Max IOL showed good visual acuity at all distances. The lens showed high patient satisfaction. We are very happy with good optical quality under different light conditions. Spectacle independence was 80% with good contrast sensitivity at 3 months post-operatively in the examined patients so far. You remember we had only 10, 2 had minor glasses. So that needs our attention. But overall, I can conclude that this lens had been in our study, it's a study cohort, quite a nice outcome, and we see very happy patients with a good function in the range of distance near and intermediate. So I'm looking forward to our outcome. It will be coming a journey till the end of the year. Then we most likely are finished and going to submit this paper for publication.
So how many is the total study number going to be? You mentioned it'll be finished by the end of the year. So what's the total end number you're looking at?
On all these studies, we do a power calculation beforehand. So I think that the total number has already been reached. It's a range of 30, something like that. I know it's a low number, but as these studies, it's not a multi-center trial, it's just a single center. My expectation is usually when I see 20 to 30 patients, and we study them so intensively like we have, then I usually know what the lens can bring you.
Yeah, no, your point's well taken. I mean, to do those defocus takes almost like 2 to 3 hours to get accurate defocus curves properly. But the value to us as clinicians is a lot. Apart from the presentations, we get learn a lot about the lens in the individual. But the individual patients, it's a real task to get them to come back. So it's a challenge whenever you're doing these studies in that much detail. But it's great to have that data. Okay, so I'd like to thank all the speakers, especially Thomas, for coming in at the last moment as well to make it. And I'd like to thank Teleon for organizing the session, and enjoy the rest of your meeting at ESCRS in Vienna. Thank you.